Hi, everyone. This is Christy Bird McKeeve. I'm the CEO of Healthy Rural California. And today we're going to record Sarah Katris-Tyler, who has been a project assistant with us for over a year now, supporting the launch of our new Family Medicine Residency program and a bit of the Psychiatry Residency as well. And in this process, we've begun to figure out what more we might be able to do in the community, but also trying to understand from ACGME requirements viewpoint what is possible. So I'm going to hand it over to Sarah. Thank you so much for putting this excellent presentation together, Sarah.
You're welcome. Hi, everyone. I'm Sarah, and this is just going to be a brief, quote unquote, residency program interview looking at OBGYN, Peds, internal med, and general surgery. So first off, some good news. A lot of the general requirements we at HRC already have. Most of these would only need a few tweaks to fit the programs in question. The reason we have them is because we've already worked through a couple of other programs before, and they're general requirements, so they kind of fit with everything. So stuff like a designated clinical site, well, we've got Enlo partnering with us now, so that fulfills quite a few requirements, though as we'll see, it's not necessarily everything. Cough, cough, pediatrics is coming. PLAs for clinical sites, those can be reworked as we've done with family medicine. Goals and objectives will have to be different for each specialty, obviously, but other than that, they can be tweaked. Evaluations, all these wonderful evaluation types like summative evaluations, semi-annual, faculty, and program have templates already. We would just have to fix them a little bit to fit the specialty. And then things that are like spatial requirements, so lactation spaces, office rooms, computers, meeting rooms, anything that we have already there, it's already there. You don't need to double it. There is some bad news though. So every specialty has some hurdles to overcome. Most of them are personnel-based. A few of them have some spacing issues. So let's tackle them all one by one. So first we're going to start with OB-GYN, aka, oh no, specialists. So OB-GYN is a little bit different from FM and Psych, which is what we've been doing before, in that we need subspecialty faculty. It is a requirement that we have to have them. They have to be board certified from the ACGME, and we need one from each of these subspecialties specifically. Complex family planning, female pelvic medicine and reconstructive surgery, gynecologic oncology, maternal fetal medicine, and reproductive endocrinology and infertility. The manual does state that some exceptions can be made, but we've seen with Psych that what the manual says, especially regarding exceptions and what the review committee will actually allow, are two vastly different things. Usually, if they say that they'll let exceptions happen, it's very rare that they actually will. We're also going to need some facilities, so kind of going off that note a bit. The ACGME requires certain inpatient facilities, labor and delivery unit, which makes sense, it's OB-GYN, operating rooms, recovery rooms, intensive care units, blood banks, diagnostic laboratories, imaging services, and all of those have to be available on an emergency basis. Continuity clinics are back, sort of. Unlike in family medicine, this requirement is an ambulatory care requirement. So continuity clinics, maternal fetal medicine clinics, and gynecological clinics that provide appropriate continuity of patient care, quote unquote, all satisfy this requirement. So it's not necessarily just one type. It kind of bleeds into a couple different types. They will need 120 distinct half-day sessions in these clinics over the course of their program. And the kind of kicker with analytics and stuff is we're going to need a rough estimate of the number of patients seen per PGY year in these clinics for the application. It is a rough estimate, so it doesn't have to be an exact number, which is good. Obviously, if you don't have residents, you don't know what the numbers are going to be yet. So just a very rough guesstimate. Which brings us to data gathering. So family medicine had a lot of data gathering. OB-GYN also has a lot of data gathering. They specifically have a list of procedures, and they want to know how many of those happen in a year. It's a much smaller list than what would be needed for like family medicine, thank goodness. Though there is an added component in that you can't have an OB-GYN program without another residency program present, and they're going to take that into account. It's a very simple little calculation that you have to do. You basically just have to say, how many of these do you think are going to be tackled by, say, your family medicine residents? How many will be specifically the OB-GYN residents? And yeah, it's just a percentage. It's rough again. You don't need to know the exact numbers yet because you don't have the residents yet, but just an overall estimate. Still somewhat of a weird rule in my opinion, though. Just the fact that you have to have OB-GYN with another residency program resident present. But hey, I'm not the ACGME. There's a table for indicating which procedures residents will perform, assist in, or learn. That one's bigger and spans a couple of different specialties. And we've got some minor issues. PGY1s need surgical training. I don't foresee that really being an issue. I just wanted to point it out. Residents need to follow all the surgical process, pre, during, and post. You're gonna have to have chief residents. Every single resident needs to be a chief resident at some point before graduation, 24 months before they graduate. They need to serve as a chief resident for 12 months, so a full year. And they basically just need more autonomy than regular residents. This is the sort of stage of their training where they're preparing for full practice. A couple more. We have to have at least 3 residents per PGY level for a minimum of 12, can't have less than that. You do have to list your didactic sessions that you have planned out with titles. And yeah, that was a lot of things. So we're going to do another one. Internal medicine. It's the same thing. Oh no, specialists, but there's a twist. Subspecialties are back. We need them again. They have to be board certified from the ACGME, just like before, and we need one from each of these subspecialties. These ones are different. Cardiovascular disease, critical care medicine, endocrinology, diabetes, and metabolism, gastroent, geriatric medicine, hematology, infectious disease, oncology, nephrology, pulmonary disease, and rheumatology. But, and here's the fun part, unlike with OB-GYN, the faculty members can be remote. They don't actually have to be there, and they can be associated with multiple residency programs. And, fun one, PDs and APDs can serve as these subspecialty faculty too. So internal medicine's a lot more lenient on sort of what they require for their subspecialties. They still require them. You have to have one of each. But the remote is a very nice thing to have. Just for fun. There's some couple of required experiences outside of those subspecialties too. Hospice and palliative medicine, addiction medicine, neurology, and continuity clinics are back. The review committee prefers residents stay at a general internal medicine clinic, as they say, but they will allow some of the requirement to be fulfilled at some sort of subspecialty or specialized clinic, like an HIV clinic, if it aligns with the residents' desired post-residency interests, and it allows them to develop the therapeutic relationship with their panel of patients. Now we've got some hour requirements. 30 months of clinical experience, longitudinal experience in an acceptable clinic, which is what we were talking about before, basically. 10 months of foundational internal medicine experiences in outpatient specifically, 10 months in inpatient specifically, 2 months critical care experience, but no more than 6 months, and you can't do it all in PGY1. It's a very nitpicky little rule there. 6 months of individualized educational experiences, which are just electives. Big old fancy word for electives. You also can't overload your residents. This is kind of important. There are limits for PGY1, PGY2, and PGY3 years. For PGY1, this is a strict limit, no more than 5 new patients per admitting day, no more than 8 within 48 hours, and they can't see more than 10 at any one time. PGY2 and 3, it's more dependent on if they're supervising PGY1s. If they are, they can't take more than 10 new patients a day, 14 transferred patients, 16 within 48 hours, and no more than 14 patients at any one time. Don't ask me how the math maths, but the math maths. PGY3 residents, it's a little bit more lenient. If they have an interest in hospitalist medicine, you can exceed the numbers. You do have to monitor and report the numbers because the ACGME needs to know that you're actually looking at this. And so you have to gather data on those, as well as the census, complexity, and acuity of the patients, which is a lot of data gathering. Which brings us to, yep, data is back. A little, at least. You need faculty who can teach data analysis a bit too, but it's very, like, this looks very scary, but it is stuff that you're probably already doing in your practice. Semi-related, the residents need to have an experience in telemedicine, because telemedicine is around now. Now we've got imaging. POCUS, which is point of care ultrasound, is a requirement in family medicine, and it's back here. Now, internal medicine doesn't say it's required, but the guidelines in their wording very strongly suggest it. So basically, it's required. Program director requirements. The program director has to have experience working as part of an interdisciplinary, interprofessional team to create an educational environment that promotes high-quality care, patient safety, and resident well-being. It's a question from the application itself, which is why it's worded so funky. Will be expected to speak to this. If we have over 15 residents, the minimum you can have for this program is 9, then you need to hire at least 1 associate program director too. That number scales up with the number of residents we have. So if you have over a certain amount, then you have to have two associate program directors, et cetera, et cetera. APDs have to participate in academic societies and educational programs, and then some more minor issues, which are likely not issues. The program has to be scheduled to offer as much longitudinal experience as possible, and it can't conflict with inpatient responsibilities. You have to list your didactics. This one wants conferences too, which, yeah. If residents can't attend a conference, we have to provide some online other format where they can get the information. Don't get scared by conference. It's just a lesson. Residents need scholarly activity. This is true of all programs, but this app specifically wants us to write down what we're planning to offer in a paragraph or two. When adjusting our evaluations, this app specifically has a few nitpicky things it wants added: data analysis and gathering, physical examination skills, clinical reasoning, patient management, procedures. The board wants to see all of those things evaluated, so they have to be in the evaluations. You still with me? Great, we're halfway there. But then we hit pediatrics, aka who knew caring for kids was so hard? Parents. Parents did. Also, the application for this one's just a bunch of number crunching. So there's a pattern here. Subspecialty faculty is back. Hello. Pediatrics gets weirdly nitpicky and yet not nitpicky with their subspecialty faculty because they want, get ready, the list is huge. All of these, I'm not going to even go off saying all of them because the list is quite large. Wow. Yeah. So all of those and then 5 of those. And if those lists weren't scary and big enough, they are not the only lists because you also need 4 of these. There's a couple of them that overlap from the last list, but not all of them do. And yep, it just goes on and on. There's a couple of familiar faces in here like neurology, nephrology, hemonc. Pulmonology's in here. Hello, rheumatology. Yeah. It's a big list. I'm gonna go back actually real quick so we can just, it's a big list. But wait, if that wasn't terrifying enough, there is more. Because there's even more faculty we have to have. Board-certified diagnostic radiologists, pathologists, and general surgeons, ideally 1 of each. And for every 5 residents you have to have 1 board-certified pediatrician who has to serve as core faculty. So if that wasn't terrifying, now we're going into reporting. It wants a lot of data, just like FM. You have to collect total pediatric admissions for a year, average daily census, average length of stay, daytime and nighttime, yes, separate data for the number of residents on service acting as primary providers, including FM, categorical pediatric residents, combined program residents, and other, which you would have to specify. Planned average number of patients for each caretaker, planned total number of residents providing direct or indirect supervision, faculty doing supervision, and types of patients cared for at each inpatient unit, which actually in terms of forms with pediatrics, that one's relatively simple. And there's some diagnoses, which is not relatively simple. Every participating site with inpatient experience has to give us 2 separate lists of 100 consecutive final discharge diagnoses for patients 20 years old or younger. It's only for the pediatric TC service. You do not include PICU. PICU will come up again in a second. We need to include average length of stay for the 100 patients, summaries for all of them, and there are summary criteria that you have to follow on the application. They have to be from 2 different time periods in the last 12 months. And you have to document the beginning and the end dates for the 100 each time. We don't include term newborns, NICU, PICU patients. Surgical can be included if they were cared for by pediatric residents. 1-day admissions can only be included if they involved significant resident involvement. And then you get to do it again for the PICU. I said it would be back, but they only need 50 diagnoses. Yep, only. And then you have to grab some stuff for the NICU too. Level designation, annual admissions, number of beds, daily census, average length of stay. Yep, this is so much data gathering. Number of deaths, fun stuff. And we're not even done yet because the daytime, nighttime data comes back too for this one. It's the same exact case as the inpatient data we were gathering earlier. Oh yeah, and that daytime, nighttime stuff, you got to do it for the PICU too. This application is a ton of data gathering. And it also wants to know if post-operative cardiac patients were admitted to the unit and other surgical patients as well. And they recommend, and again, when they say recommend, it's really a requirement. Use the same 12-month period for everything. It makes the form so much easier. If you use different periods, you have to start doing comparison. It's just not worth it. Use the same period. We also have to list where all of our adolescent and developmental behavioral clinics are. Adolescent clinics can be college health clinics, medicine clinics, etc. Behavioral developmental, it can be a behavior clinic, daycare center. It just needs normal and abnormal behavior and development. You have to list them, the number of half days the residents will be there, and the average number of patients seen per resident per half day. Oh, and the ED is here too, which is fun. The duration of the ED experience, total visits per year, percent of patients under 22, actual times that are staffed by the residents, so you have to include when your residents are actually there, number of patients per resident per shift, supervisor name. Continuity clinics back too. You want the ratio for preceptor to residents there, the number of PGY1s you've assigned to the clinic, for the number of clinic sessions they have in a year. Same thing for PGY2, same thing for PGY3. Combined residents per number of sessions, which is just going to be the total of all of those. Total number of primary care visits per year, etc. Residents need to write admit notes and/or orders, progress notes, and round daily to address medical problems in the inpatient, NICU, and PICU. If that's not possible, you have to explain how the residents are getting their surgical experience with pediatric patients because they need that. You have to have assessments for procedural competence ready by the day of the site visit. The site advisor will ask to see them. Residents have to complete PALS training, maintain certification in NRP, and get training in simulated intraosseous line placement, which I've probably butchered that name horribly. Blocks have to include things too. It just goes on. Pediatrics is kind of a nightmare. Individualized curriculum, which is electives again, inpatient peds, neonatal intensive care, critical care, newborn care, adolescent medicine, developmental behavioral pediatrics, subspecialty experiences, the 5 from that really, really long list, ambulatory care experiences, pediatric emergency, NICU, PICU, and they can be actual blocks or longitudinal. If they're longitudinal, they get separate requirements for that. We're not done. Didactics and research. We have to list didactics out too, except this time you have to even list who's responsible for giving the conferences, so they want names. You also have to list ongoing research projects in the department, like title, funding, was it awarded by peer review or not, the years of the funding, total cost of this, and the faculty investigator and their role in the grant. They get really intense with this. We're on a last tiny little requirement though, so it's almost over. Night calls have to have their own goals and objectives, just for fun. Pediatrics terrifies me, if that wasn't obvious already. But we're almost done, that's the good news, yay. General surgery, aka this one looks deceptively simple. Compared to pediatrics, it's not deceptive, it is simpler, please. Oh my gosh. Because the subspecialties are gone, yay. There are curricular requirements though. Residents have to have experiences in, this doesn't have to be board certified, applied surgical anatomy and surgical pathology, the elements of wound healing, homeostasis, shock and circulatory physiology, surgical infection, hematologic disorders, immunobiology and transplantation, oncology, surgical endocrinology, surgical nutrition, fluid and electrolyte balance, the metabolic response to injury, including burns, and they are very specific that they want burn experience, immunology and immunosuppression. Yeah, some more curricular requirements. 54 of your 60 months need to be on clinical assignments in surgery specifically. Some of that has to be emergency care, and some of that has to be surgical critical care. 42 of those 54 months need to focus on the essential content areas of surgery. That is directly ripped from the requirements. They did not specify what the essential content areas of surgery were. Chief clinical assignments should happen in PGY5. Chief residents can't focus on the same essential content area for more than 6 months. Do not stick them all on the stomach, for example. You gotta put them in other things. Residents need outpatient experience of 1 half day per week. And scholarly activity is back. It says, oh no, don't worry about it. You have to list grand round topics planned for the program. That should be fine. It can be a tentative list, not a final one, which is nice. You do need to list whether faculty or residents are presenting, so if you plan to have your residents present, just put them down as, tentative presenters. Same for conferences and for journal club. Some small requirements. You need pathology and radiology services to support the residents, as they are surgical residents. You need to chart all of the other subspecialties in the facility and how many residents they have. You need simulation and skill labs. 1 core faculty member per chief resident is ideal. You have to test competency in comprehensive patient care planning, including pain management and dexterity, because they will be doing surgery. Residents need a QI activity or a project. There's also morbidity and mortality conferences. And all of that didn't seem as bad, especially hopping off of pediatrics, right? But we do have one singular catch that makes this deceptively simple. There's a list of procedures. The list of procedures is so long that they could not provide it in the actual application itself. They have to provide it in a separate document. You have to take every single clinical site, give them that list, and fill out how many of each procedure that they perform per year on the whole list. It's a lot. Takes up half of the empty application page alone, which is again why it's in a separate document. And that's page 1 of it. If you look down at the very, very tiny corner in that very faint gray writing, you'll see that that's specifically page 1 of 18. It's a really, really big form. But that's it. If you can get past that, you've got general surgery. So thanks for listening, and I'll hand it back to Christy.
Thanks so much, Sarah. I so enjoy listening to your presentation because you bring humor into something that must not have been very fun when you went through all of these applications from ACGME and listed all of this out. So thanks for bringing some humor to it. I did have a question though for you. Is there a minimum number of residents for surgery? And if you don't know that off the top of your head, that's okay. I
believe I don't know that off of the top of my head, and or it wasn't directly mentioned in the application itself.
So if it wasn't mentioned, maybe there's some leeway. I can look that up, but it is a 5-year program.
It is a 5-year program, yes.
Yeah. I did want to add on that we understand research is very important for at least internal medicine. Most programs, we understand, look at the liver for research. And so I just wanted anybody who's listening to this, thank you for staying with us this whole time, but also that we at Healthy Rural California, as we build out the Psychiatry and Family Medicine Residency, are looking to build up that research sort of portfolio. There is research happening at Chico State here in Chico where these residency programs would be centered, but we also have partnerships with UC Davis, with Stanford, with Touro University. So those 4 schools have some good basic basis for research, and we're just trying to put that together so that when the residents and medical students too come on board, they have an ability to jump into some of the projects that they're most interested in and support. And then I just wanted one more note, which is we have such a need for pediatricians in Chico specifically, and in this region of the rural and underserved Northern California. And so I'm going to explore what it might take to have sort of residents from another pediatric residency do an elective here or something like that, because it's clear that Chico does not have what it would take to sustain its own residency program for pediatrics. But we have some really great partnerships. And I think that recruiting of, pediatricians might be strengthened, but also maybe there's some residency electives that would bring those residents to this community. So just trying to be innovative and problem solve what is obviously something we can't sort of have in the community ourselves. So that's all I wanted to say. Thank you so much, Sarah. Anything else you wanted to comment on? Or you've been a member of this community for your entire life, and I think you've been particularly interested in family medicine as you hope to become a family medicine doctor in the future. But anything else you wanted to say?
Just thank you all for your good work. Yeah.
All right. Thank you.